Okay. So, good morning. So, my first talk will be on update on stroke management. So, it's a big topic. So, I'll be quickly trying to cover ischemic stroke, hemorrhagic strokes, and venous strokes. So, I might take 2 minutes extra, but I'll make it up in the next talk. So, coming to the ischemic stroke. So, as you know, the whole basis of acute stroke treatment is when you have a acute stroke, you have something called the core. That is the area of the brain which is already damaged or just about to get, which most likely to get damaged. And then we have an area called the penumbra, which will get damaged in the next few hours. So, and finally, if you don't treat early, we'll get a large infarct core like this. And all this happens very quickly in the first 4 to 6 hours. And this is what we are trying to prevent by saving as much as the penumbra as possible. Right. Now, there are 3 things we can do. One is to recanalize the blocked artery. At the same time, we have to maintain good collateral flow to the area called the penumbra. And there are a lot of, like every month or every other month, you'll see a new neuroprotective agent coming into the market. So first, right now, there are no proven neuroprotective agents for stroke. So it is wasting your money if you write something which your medical reps may be promoting. There is one trial which has shown some promise, that is sublingual edaravone. So it is yet to come out. Coming to the maintaining the collateral blood flow, it is the most important thing here is never to reduce your blood pressure abruptly in a patient with acute stroke, which is very, very important. And hope all of you knows the target of BP in a patient who comes with a acute stroke. If you are not thrombolizing, a BP of 220 by 120 is permissible. Only beyond that you need to treat. Now coming to the recanalization, this is the only definitive treatment we can do, but there is a time-bound problem here. If you want to give IV thrombolysis, you have to give it within the first 4.5 hours, 4.5 hours window. So now, if you look at this graph, you're seeing the relationship of thrombolysis and odds for a favorable outcome, even within this 4.5 hours window. You can see here in the first 90 minutes, the number needed to treat is 4.5, but in the next 1 hour, it doubles to 9. So even within this short window, you have to act quickly as possible. And the more down, you go further down the time window, and there is a higher chance of having hemorrhagic transformation of your infarct. Now, for IV thrombolysis, we have been using this drug called alteplase since 1985. And now there is we have this tenecteplase, which we are all using now. Most of the institutions have changed over from alteplase to tenecteplase. So what is so great about tenecteplase? So if you compare these two, first is tenecteplase is almost 100 times fibrin selective rather than when compared to alteplase. So that is very, very important when you treat. And the second thing is it doesn't get inhibited by plasminogen activator inhibitor 1. So when you give these lytics, basically you're trying to activate plasmin to lyse the clot. At the same time, there is a plasminogen activator inhibitor in our body, which will try to destroy this. So this doesn't get affected by PA1 inhibition. And the most important thing is the half-life. If you look at the half-life of alteplase, it is only 4.8 minutes. So very short acting, whereas tenecteplase is longer acting, 11 to 20 minutes. So if you have to give alteplase, usually you give a bolus, and then you'll have to infuse it over 1 hour to maintain this because of the short half-life. Whereas tenecteplase, we can just give a bolus, IV push as a single bolus over 5 seconds, and you're done with that. So for all these reasons, tenecteplase is now the preferred drug. And moreover, it's not much cheaper, it is cheaper than alteplase. So this is the landmark trial called the ACT trial, it's a North American trial which showed that tenecteplase is non-inferior to alteplase. So this is what most of the centers are using now, tenecteplase. Now, so with such a drug, the question is, being more fibrin selective, can we extend the window beyond 4.5 hours? Because all the trials have been using alteplase. So now there are a lot of trials which has been last actually 2-3 months, which has come out to see whether we can increase the window with tenecteplase beyond 4.5 hours. So these trials are now showing a mixed results, but the only good thing is the hemorrhagic complications are much less than expected with tenecteplase. So there is still promise, and we might in the next 2 or 3 years see tenecteplase being used beyond 4.5 hours window IV. Now, what are the drawbacks of IV thrombolysis? So the first thing is the site of occlusion. So it depends on where your which artery and where it is occluded. So these are the recanalization rate at 8 and 24 hours after thrombolysis. So you can see here, the more distal the vessel occluded, the more likely your thrombolytic agent is going to work. So you can see here, if you have a M1 occlusion, it is only 50% that your lytics is going to work. If you come down, say T occlusion, that is the bifurcation of the carotid, it's only 15%. So this is very, very important. And also the length of the clot. If you have a clot which is more than 8 mm, it's very unlikely your lytics is going to be of use there. So whenever you have a large vessel occlusion, what you called as in stroke medicine, we call it as LVO strokes. That is internal carotid artery, middle cerebral artery, or basilar artery occlusion. What we have to do is, if the patient is within the 4.5 hours window, we have to give both IV and then take the patient for mechanical thrombectomy. So these are some of the landmark trials looking at endovascular treatment with bridging. You give IV and then take the patient for mechanical thrombectomy. And you can see here the number needed to treat is, all of them have less than 10, and some of them are having even less than 5. So what if a patient comes just beyond the 4.5 hours window? Say patient is coming to you, say 6 hours after the stroke. Can we do anything? So here we have to show that there is a penumbra still existing. If there is a penumbra, then we can opt only for mechanical thrombectomy. There is no role for IV thrombolysis beyond 4.5 hours window with the penumbra. So how to demonstrate there is a penumbra? We can do advanced imaging like a diffusion flare mismatch, which we commonly do, or a perfusion imaging. But most important is you're using your clinical judgment. You can use what you call as a clinical radiological mismatch. Suppose somebody has come with, say, neglect, and you're seeing on the scan only subcortical areas are involved, you know that there is a penumbra in that patient to be salvaged. So these are, and now the the last few years, we have these softwares. So as soon as you do the scan, it will tell you like how much core is already involved and how much penumbra is remaining. For this example, it is showing that there is a penumbra 124 ml yet remaining to be salvaged. So these are softwares we can use if the patient comes beyond 4.5 hours window to choose which patients we can subject for mechanical thrombectomy. So these are the two landmark trials called the DAWN trial and the DIFFUSE trial. The DIFFUSE trial took patients from up to 16 hours, and the DAWN trial took patients up to 24 hours using advanced imaging software. But the main thing here is what you should understand here is all these trials, they took patients with a small core, that is less than 70 ml of core. And roughly you can say that all these patients had less than 1/3 of the MCA involved in the acute stage. So these are the patients who might benefit for mechanical thrombectomy beyond 4.5 hours window. Now, the last 2 years, there has been a lot of trials looking at large cores. Like what about patient coming with large core, whether we can still make them undergo mechanical and whether they will be benefiting. And some of these trials results are out, but in the next few years, in the next 1 year, we'll be having more uh, information on large core trials. So as you see, the in ischemic stroke treatment has progressed a long way from 1995, where we started using IV TPA. 2015 was a landmark year where we had this large trials looking at mechanical thrombectomy and extended window trials in 2018. And now we have the large core trials going on, and people are even looking at beyond 24-hour window in acute strokes. Right. So what we are seeing is we are shifting from what you call as a time clock based treatment to a tissue clock based treatment for ischemic stroke, basically targeting the salvageable penumbra and extending the window as we go down the line. Now, shifting gears and coming to intracranial hemorrhage. So what is new in intracranial hemorrhage? So now we know that when you have a patient coming to the emergency with a acute hemorrhage, most of them will have hypertensive bleeds. We are talking only about hypertensive bleeds here. That is what all of us will be seeing. So the hematoma expansion occurs in the first 6 hours in most of the patients. So what so patient comes early, can we do something to help the patient? That's the question. What we can do to prevent the hematoma from expanding. The main thing here is what studies have shown is there is only one thing, that is BP reduction immediately within the first 1 hour to less than 140 and maintain it. So I have underlined two. One is first 1 hour it has to be reduced to less than 140 and maintain it less than 140. Now, what about hemostatic agents? Can we give any drugs to prevent the hematoma from expanding? So this drug called Novo-7 or recombinant activated factor 7 was a big hit some few years back. Everybody was using it. Now there is evidence of level A evidence of harm of MI if you use this drug. So please don't give Novo-7 to any patient who comes with hemorrhagic stroke. Tranexamic acid is something which is shown going to tell us in the next 1 or 2 years. Trials are going on in tranexamic acid in acute hemorrhagic stroke. Our department is also involved in this trial called the intrinsic trial, which using tranexamic acid within 6 hours of hemorrhagic stroke. What about oral anticoagulation induced bleed? So now we are starting using more of NOACs and even warfarin. So we are seeing a lot of almost 20% of the bleeds which comes to the emergency can be on oral anticoagulants. So here what we have to know is instead of expanding for first 6 hours, patients on oral anticoagulation, they can keep on, the hematoma can expand up to 12 hours. So we have a window of 12 hours to work on and do whatever possible to prevent the hematoma from expanding. So if the patient is on warfarin, so here we immediately have to give vitamin K. But the whole problem with vitamin K is it will take 12 hours to start working and the full effect will come only after 24 hours. So we have to give either FFP or prothrombin complex concentrate. So here we have to go for 4-factor PCC because we don't have time. So if you have to give fresh frozen plasma, first you have to go ask the blood bank, get it, thaw it, then give it in a blood bag. By the time the whole story is over, your 12 hours will be over. So right now we have readily available prothrombin complex concentrate in the market. There are 2 brands. One is Prothrom and second thing is Octaplex. Both of us we are using now in neurology for acute hemorrhagic stroke, which comes within the window. So just go for 4-factor PCC. What about NOAC-induced hematomas who comes early? So here we have specific antidotes for each of these NOACs. The patient is on dabigatran, you can reverse it with a specific antidote called edoruximab, which are actually monoclonal fragments which will go and bind to the dabigatran. And similarly for apixaban and rivaroxaban, we have adenosine alpha, which is again a decoy protein. And similarly, we have for edoxaban, which we rarely use. So for all these agents, we have specific antidotes we can use. And this antidotes we can use only if they have taken the drug within the last 24 to 48 hours. If the patient has taken a drug, these drugs beyond 48 hours, there is no role for these antidotes. Suppose you don't have any of these with you, the next best thing is again go for 4-factor PCC. Now coming to surgical intervention in hemorrhagic stroke. So if a patient has a large cerebellar bleed, more than 3 centimeters and more than 15 ml, especially if it is associated with brainstem compression or early hydrocephalus, studies have shown there is a better outcome if you do surgery early. Don't wait and wait for the score to drop. What about brainstem hemorrhage? Suppose the patient comes with a pontine bleed, like this patient, there is no role for surgery. Superficial supratentorial lobar hemorrhage, like this patient, which are the patients who will benefit with surgery? So this is meta-analysis of multiple trials. So we have to choose the patients carefully. First of all, the patient's age should not be too much. The best is less than 65 years. Important, GCS should not be too good, not too bad. It should be between 10 and 13. This is the group which was found to be benefiting maximum with surgery. And don't wait. If you beyond 48 hours, there's not much of benefit. Best if you do surgery within 12 hours. And the most important thing, two things. One, the bleed should be less than 1 centimeter from the surface. Second, there should not be intraventricular hemorrhage. So these are the subgroup of patients with superficial supratentorial lobar hemorrhages who will benefit with surgery. So suppose you call your neurosurgery team, they might tell you, wait for the score to drop. So please tell them we have evidence now. Okay. Right. Next, what about deep-seated supratentorial hemorrhage? So this was something which people never used to bother because there's no evidence for surgical evacuation of this deep-seated supratentorial hemorrhage. So right now, there are a lot of work going on in minimally invasive clot evacuation for this group of patients. So there were two trials called the MISTY trial, where you put in a catheter into the clot, into the bleed, and then you take it out. And you can even instill some alteplase to make the clot less liquidy and then take it out. Another trial which got published this year is called the ENRICH trial. So here they use something called the minimally invasive perifascicular surgery. So what they did was they were going between the fibers without cutting it. So there is no damage to the brain when you are approaching the clot. And this study was found to be useful for anterior basal ganglia, ICH, with patients with GCS of 5 to 14. So there is a new study which is coming up in India, which we are also part of, using minimally invasive surgery for hemorrhagic stroke, deep-seated ICH. So this is an exciting field. In the next 1 year, we will be having a lot of data on minimally invasive surgery. We have trials from China called the Eminent ICH and other trials which will be published soon, and we'll get more data on this. So what we have to realize is in hemorrhagic stroke, right now, if your patient comes early, we cannot relax and sit back and say, oh, this is just a hemorrhagic stroke. There is something called care bundle approach for acute ICH. Okay. So first of all, make sure the patient is not on anticoagulation. If he's on anticoagulation, within 90 minutes of arrival, you should have reversed it. Second, there is something called door to needle time in ischemic, in hemorrhagic stroke also. That is the targeting your blood pressure. Within 60 minutes, you should have brought down your BP to less than 140. If the patient has a cerebellar hemorrhage, which is more than 30 ml, please inform neurosurgery ASAP. And also for the superficial supratentorial bleeds also, you have to inform them immediately. And like in ischemic stroke, we have targets of sugar and temperature. Make sure they don't exceed. So like we have a window for acute hemorrhagic stroke also. And it has been proven if you use this care bundle approach, the patients are going to benefit. Now coming to the venous strokes. So this is something which our neurology department has been doing a lot of work, and we have published a lot of seminal articles on CVT from CMC Vellore, our department. And we have the CMC Vellore CVT registry, which is the largest in the world, more than 2,500 patients in our registry. So this is one of some studies which showed that there is something different on CVT. So this is a study. We thought, why was patients, whether there is any seasonal trend for CVT. So we took patients from our adjoining 5 districts and looked at the seasonal trend. So as we suspected, there was definite increase in CVT cases coming to us in the summer months from April, May, and June. This was a large study involving 1,250 cases. And also, when we did a time series analysis, we found that this trend was consistent across all the 18 years we studied. So this is something which we could prove that definitely there is a correlation between climatic condition and the occurrence of CVT. Now, gender difference in CVT, this is something, another thing which we found. So usually if you read your textbooks and any article, you'll find that females are more prone for CVT. So this is something which we looked at. So if you look at this graph, we took all our cases in the last 21 years. So when you plotted it, we found that, yes, there was females were more, CVT cases were more till say 2010. But once you cross 2010, you can see this male patients in green. It's slowly creeping up. And now in the recent years, male patients have overtaken the female patients. And so when we shared this data, it was true in other parts of the world also, that nowadays we are seeing more male CVT cases than females. And this is, when we looked at it closely, this was mainly driven by the fact that the number of postpartum CVT cases have been coming down drastically because of better obstetrics care and Dr. Soumya's contribution. Right. Now coming to the treatment. So the definitive treatment in CVT is to occlude your, so open up your occluded venous channels. So there was always the debate of role of mechanical thrombectomy in CVT, like in ischemic stroke, whether we can go in and take out the clot if provided the medical treatment is failing. So if you look at this interesting chart, you can see this is all the endovascular treatment for CVT published from 2007 till now. So earlier years, we are also published using Penumbra device. So if you look at this, till say 2019, there was no, actually if you look at, there's no benefit to smack in the middle. But since 2019, all the studies have shown there is definite benefit for endovascular treatment in CVT. There is only one RCT looking at this, which was negative, but it was published before the 2019. So actually, there is no particular catheter we can use for doing mechanical thrombectomy in CVT. We have to depend on the devices which you use for stroke treatment to pull out the clot. And this is something which we did. We used this mechanical thrombectomy using Fogarty balloon catheter. So this is very cheap. And we could show the world that we can do it for $600 US when compared to other countries. They have been doing it for, say, if you open a Penumbra kit, it will come to easily 2.5 lakhs. So now coming to the role of surgery in CVT. So everywhere they were doing surgeries, but there was no big studies to show that benefit of surgery in CVT. So this is an example, a large hemorrhagic infarct like this comes, and the only thing we can save to do to save the life is to do hemicraniectomy and decompress the brain. So whether it is worth doing it, what is the outcome? It is a big question. So, I mean, as I told you, there were a lot of case series and reports, and the biggest one was from our institute way back in 2013. We had 44 patients who had undergone surgery, and they were having good benefit, like 77% survived. And at the end of 1 year, we could see that MRS was excellent at 6 months and continued to improve. So we thought of doing it in a bigger way. So we had an international collaboration, mainly from European countries, and we did this trial called the Decompress 2 trial, which was published this year. So what this study done is, it was a large study from 10 countries involving 15 centers from Germany, Portugal, Spain mainly. And so what we had 118 cases, and at the end of 1 year, we could see that 2/3 of the patients were alive and 1/3 was independent. And moreover, the surgery was judged worthwhile by 4 out of 5 patients and caregivers, which was very, very important. And if you compare this with your surgeries you do for your malignant MCS strokes, the mortality was slightly better, but the outcome was much, much better. At the end of 1 year, for CVT, the morbidity, the disability was less than 10%. So definitely it is worthwhile doing surgical decompression in CVT patient. And this is the only one study which was showing, it was a prospective study looking at the outcome longitudinally. And this has been quoted as one of the 10 practice-changing articles of 2024. So I would like to conclude by saying stroke medicine is a rapidly evolving field, and the time window for intervention in acute stroke is expanding. And now a treatment window has emerged for even hemorrhagic strokes, which all of us should be aware of. And there is strong evidence for both endovascular treatment and surgery in cortical venous thrombosis. Thank you. I'll come to the next talk. So in the next 10 minutes, we'll just looking at what is new in headache management. So for this, first of all, there's been some new way we look at the pathophysiology of migraine. So right now we know that the whole thing starts in the hypothalamus. There is something which is activating the hypothalamus, which starts the what you call as a cortical spreading depression. And when this cortical spreading depression reaches the trigeminal ganglia, it activates the trigeminal system. And once this happened, there is activation of the trigeminal sensory efferents, and there is inflammatory changes at the trigeminal nerve endings. So this is how you should be looking at the whole pathophysiology. And as you know, it's the trigeminal nerve ending which innervates most of the cerebral structures like vessels, pial vessels, dura maters, and large venous sinuses, all of which are pain sensitive. So what happens at the trigeminal nerve ending? This is important, and this is what is new in headache treatment. So at the trigeminal nerve ending, there are a lot of neuromodulators and chemicals which are released. First of all, we have serotonin. Then we have this important molecule called the calcitonin gene-related peptide. And you have the pituitary adenyl cyclase activating polypeptide. So these are the three important things which get released at the trigeminal nerve ending. And this works downstream. And then it causes two things. One is sterile inflammation, which causes two things. One is vasodilatation, and because of inflammation, you get your pain. So now, if this cascade continues, and this activating of trigeminal sensory efferents is persistingly there, what you call you get something called sensitization, and now the peripheral and central neurons become increasingly respond. Even a slight, no, even non-nociceptive stimulation can be perceived as pain. So this is when a patient with episodic migraine moves on to a phase of chronic migraine. And this is what the first step in any treatment for any headache is to prevent an episodic migraine going into a chronic migraine. So anything which is more than 15 days a month, you call it as a chronic migraine. So what are the targets of therapy we have? First, first of all, we have to do something and make sure the hypothalamic activation doesn't occur. So this is basically avoiding triggers. So each patient can have their own triggers. Some of them can be having some hormonal triggers. So we have to avoid whatever trigger in thirst, not taking food in time. All of them can, if you look at the hypothalamus, this is what influences the hypothalamus. It's a center for thirst and whatever. So avoiding triggers is the first thing. The second thing is targeting the inflammatory changes which is happening at the trigeminal nerve ending. So here you give your NSAIDs to take care of the sterile inflammation. That's what we commonly do. And to counter the vasoconstriction, we can give your triptans. So other tricks, what we give is beta blockers, which will cause vasodilatation. Sorry, vasoconstriction. So triptans can be given for vasoconstriction, and it acts at the peripheral nerve endings, inhibiting the transmitter release. So there are a lot of triptans available in the market. But what we should be knowing is there are now nasal sprays which we commonly use. There are subcute triptans. The two things about triptans is when you treat, you have to give it very early. Like you cannot wait for the headache to build up and then give, because you have to hit it as soon as the patient knows that he or she is going to get a headache. And if the migrainer has headache which is associated with nausea, then no point in giving an oral triptan, it will bring it out. So you can use other forms like subcute or nasal spray, which is widely available in our pharmacy. Now the problems with, and also always when you use triptan, you have to combine with the NSAID, because we are targeting two things. One is vasoconstriction and the sterile inflammation. So the limitation of triptan is you cannot use it for more than 10 days per month. If you do this, you'll get something called a medication overuse headache, which can be a very chronic problem for the patient and difficult to treat. Also, you cannot give triptan for patients with ischemic stroke or ischemic heart disease, because it is causing vasoconstriction. And also, we have to avoid triptans in certain subset of migraine patients, that is hemiplegic migraine, and patients who have migraine with brainstem aura. So these are the subsets of migraineurs we should not be giving triptans. So we have alternative. One is the drugs targeting serotonin. We have the group of drugs called ditans. So the lasmiditan, which is the available molecule now, the advantage of ditans is it lacks the vasoconstrictor activity. So we can use this for patients with relative contraindication for triptans, including any ischemic heart disease. But the catch here is, if you are giving lasmiditan, the FDA warning is that the patient should not be driving for the next 8 hours. So ideally, we should give this for patients whose migraine is usually occurring in the evening. So you can take then go to sleep. So that is one drawback of this lasmiditan. So right now we have other molecules which are much better, targeting the C-geriatric protein. So one is the G-PANS, which targets the receptor of the CGRP, which blocks the receptor. So in this group, we have oral tablets. This can be used for patients who fail on triptans or unable to tolerate triptans, or who gets the migraine attacks during the daytime, or they want to drive. And again, they don't have any cardiac or stroke-related contraindication. So these are oral tablets usually used for aborting the acute migraine episode. And one of these, that is the atogepant, can be used for both for migraine prevention and for abortive treatment. So you can give it as prophylaxis also. Coming to the other CGRP targeted therapies, we have now monoclonal antibodies targeting the CGRP, which will go and bind to the CGRP. These are to be given as subcute injections or IV infusion every 3 months. So very convenient for the patient. They just have to take an injection every 3 months. And the next we have the monoclonal antibody targeting the CGRP receptors, which we can just give every month as subcute injection. And this is available in India as Erunimab. The only problem is the cost, it comes to around 22,000 rupees per month for the patient. So what about Botox injection in migraine? So how Botox acts in migraine is it prevents the release of CGRP from the nerve terminals. And so you can give serial Botox injection every 1 month as per the patient's response and avoid any drugs. Now, coming to the medical devices used for migraine, there are now 6 FDA cleared non-invasive devices for migraine. So this is the earlier one called the Cephali, which was used for stimulating the supraorbital nerve. And we have the vagus nerve stimulator called Gamma Core, which can be used for both migraine as well as for cluster headache. And there are other devices targeting the trigeminal and the occipital nerves for aborting migraine. And there is even a pulse transcranial magnetic stimulation, which gives a single pulse of TMS whenever the patient has an acute migraine episode. What we use in our department is this device called the Nervio. It is a remote electrical neuromodulation device. So this is a very cool looking device. We just have to wear it around your arm, and and you can connect it to your smartphone. And we have been using it since the last say 8 months now. And many patients are really finding it useful. The important thing is this can be used for patients who are pregnant. When there we cannot give any other treatment, we can give this safely. What about nerve blocks in headache? And so we have various blocks can be tried. This is the auriculotemporal nerve block, supraorbital, supratrochlea, and even sphenopalatine ganglia block we can give. Or we can even instill topical application through the nose, and in the acute setting, we can actually give relief for the patient. And this is used mainly for treatment for acute cluster headache. As you know, acute cluster headache is one of the most devastating form of headache you can have. Patient can even try to, like 2 weeks back, last week we had a patient with cluster headache. He hung himself and he had come to the emergency. So cluster headache is the most severe type of headache one can have. Greater occipital nerve, this is what we commonly use in our department for occipital neuralgia, migraine. There are subsets of migraine patients where if you give greater occipital nerve block, they get relief of the migraine and for other condition. And something which we don't use, this is called the sphenopalatine ganglia stimulator. This is mainly used for cluster headache, where you can actually implant a device into your SPG. And whenever you get an episode of cluster, you can just remotely activate it to abort the attack of cluster headache. So in short, we have a lot of drugs and options now to abort an episode of acute episode of migraine or cluster headache. Triptans has been there for a long time. Now we have Gpans and Ditans, and these devices we can use. Migraine prophylaxis, again, we have more options now. We can use some of these devices like Nervio. We can do nerve blocks. Again, some of these Gpans, as I told you, can be used for prophylaxis, botulinum toxin. monoclonal antibodies for targeting CGRP can also be used. So thank you.
Thank you, Dr. Sanjith. I think in the interest of time, we'll take questions at the end, and I'll go on to the next speaker.